Okay. So as far as examples of each one of these, and as I said on the test, you know, I'll write out type 1 hypersensitivity, immediate IgA mediated. That's the whole title. I won't just write type 1, type 2, type 3, and 4. Right? These will be the full titles. So serum sickness, which type is that? An example of. 3. Immune complex mediated. Type 3. What's the TB skin test an example of? 4, which is delayed cell mediated. What's hives? Type 1, immediate IgE mediated. What's asthma? No, type 1. Asthma's type 1, immediate IgE mediated. What are transfusion reactions? Those are type 2, cytotoxic. And hemolytic disease of the newborn is also type 2, cytotoxic. So when we talk about these, you need to know what cell type is responsible, what type of antigen we're talking about, what type of antibody, any cells that are involved, any major mediators that are involved, how long is the reaction time, and is there a skin reaction. So the best way for organizing this information on all 4 of our hypersensitivities is Erica's favorite, a table, which they have a table in your book, but you don't have to know in as much detail as the one they have in your book. So I have my own, and of course you could print it out and try and fill it out yourself, right, when you're studying these things. So the type of antigen for IgE mediated, and this is something we didn't talk about previously. When they define the antigen, they define them as being soluble or insoluble. And for this one, it tends to be a soluble antigen, which means it would dissolve, right, in a solution. More importantly is the antibody involved. And in the name of this hypersensitivity, it tells you, right? You shouldn't miss this one. What antibody is involved? IgE. Oops, my thing goes the other way. Okay, we'll go the other way. So for cytotoxic, it's cells, right, that we attack. So is that soluble or insoluble? Are cells soluble? Do they dissolve into a solution? No, no. They're insoluble or cell-bound, right? We're attacking cells in this case. Immune complexes are usually soluble antigens. So again, relatively small. Delayed cell-mediated, this can be either soluble or cell-bound. So these can be antigens that would be, say, in your blood or in your fluids, or they can be antigens on the surface of a cell, or that attach to a surface of a cell. We already said IgE for IgE mediated, right? What about cytotoxic? IgM for blood transfusions typically, or it could also be what one is responsible for hemolytic disease. IgG, because remember, it crosses the placenta. So it can be IgG and or IgM. That could be the reason for the transfusion reaction. But as far as hemolytic disease of a newborn, it's only IgG that creates the problem because it crosses the placenta. For immune complex mediated, it's 2 antibodies again. Which 2? It's the same 2 as cytotoxic. IgG. Oh, wait a minute. It is just IgG. I messed up. Oh, that's why I was thinking IgM. Because, remember, IgM can activate complement, so can IgG. That's why I was thinking of IgM. But it's mostly IgG. And again, this is the reasoning for it, right? Small antibody, just that monomer form, lots of antigens, and you get these smaller complexes that persist. Hence, immune complex, right? IgG and antibody. Are there any antibodies involved in delayed cell-mediated? No, it's mediated by cells, right? So it is not any antibodies involved in this one. So none. So what cell type is responsible if you're talking about an antibody response? Who produced those antibodies? B cells, right? So that's true for all of these that involve antibodies, right? B cell, B cell, B cell. Who becomes sensitized? Who produces the attack cells as far as delayed cell mediated? T cells, right? Remember, our cellular response is T cells. Our humoral antibody response is B cells. So other cells involved with IgE. Remember, who does the IgE bind to? Basophils and mast cells. For cytotoxic, remember the natural killer cells get involved sometimes when they bind to IgG and cause what we call antibody-dependent cellular cytotoxicity. And the problem with the immune complex is other white blood cells, right? When you have these immune complexes, it's going to call in an inflammatory response, so you'll get things like monocytes and macrophages and neutrophils. So that's kind of a long list. We'll just say white blood cells in general, the problem, right? Responding to this interaction. Same is true for delayed cell mediated. Those T cells are going to elicit an inflammatory response. So you're going to get a whole bunch of white blood cells rushing to the area. Important mediators. So especially for IgE mediated, one of the major plays is the histamine that's released from the mast cells and basophils. And we talked about this when we talked about the potential of the allergic reaction in the fungi case study, right? And how histamine works. For cytotoxic, complement, right? Those complement proteins combine with the IgGs or the IgMs and be a major player in the destruction of the cells. Same is true with immune complex mediated, which is why for me for a second I wanted to say IgM too, because I was thinking about how complement can get activated. And for delayed cell mediated, it is the cytokines, that communication between the white blood cells that's an important mediator of the situation that's going on, right? This communication between the T cells and the other white blood cells is mediated by cytokines in general. How quickly can immediate IgE-mediated reaction happen? Immediate, right? What do we mean by when we say immediate? A minute, an hour, days, seconds, right? Within seconds. And it could take as long as 30 minutes, depending. But for most people, right, we know it can happen literally within seconds of exposure. Cytotoxic. This can take a few hours, even days. For immune complex mediated, again, this varies quite a bit from hours to days. For delayed cell mediated, as the name implies, this is going to take a while, right? So typically 48 to 72 hours, which is 2 to 3 days. And that's why, right, 2 to 3 days after the tuberculin test, that's why they're checking. Because it's going to take that long for the cells, enough cells to migrate to that area where you get that indentation, you get that positive reaction in the skin. So with IgE mediated, can you get a skin reaction? Yeah, we typically refer to that as hives or the wheal and flare. Doesn't always happen, but a skin reaction can happen for IgE mediated. Does a skin reaction happen for cytotoxic? No. Right? This is happening in your blood. Immune complex mediated. Could you get a skin reaction? Yes, you can. And the name given to that is referred to as arthros. Delayed cell mediated. Well, we know with the TB test, right? It's a skin reaction. So sometimes, yes, you're going to get a skin reaction. You may even get necrosis like we saw with poison ivy and poison oak, even for some people with the other types of allergies like nickel and such. It can get quite inflamed and even necrotic. It's referred to as an induration, right? It's the influx of cells that will happen for a positive TB test. So again, good way to organize all the major components of the different hypersensitivities that come into play. This is a table, I think, similar to the one in your book, right? And so I just kind of streamlined it down. But this one actually has some examples, some that we talked about, others that we did not talk about. So, transplant rejections. What are the antigens, what are the things on our cells that our immune system isn't able to properly communicate with that causes a major problem with tissue and organ transplants? MHC, right? Major histocompatibility complexes. So in this case, they are the antigens. They're the foreign substance to the cells, right? These cells that you get in this cell or tissue or organ transplant. What immune cells, therefore, are responsible for allograft rejection? Who can't communicate with these cells because they don't recognize the MHC? Which one of your cells communicates with MHC? Which one of your white blood cells? T cells, right? T helper cells communicate with MHC class 2, which is your antigen-presenting cells, like your macrophages, your dendritic cells, and your B cells. So that's really not the problem here. It's class 1, right? And who interacts with class 1? Which is found on all your cells, including those ones you had transplanted. Which T cell communicates with MHC class 1? Yeah, the CD8. And what's the name for those cells? 8. The number 8. Sounds like eat. Cytotoxic T cells. So what are they going to do? They're going to destroy those cells, right? Because they can't communicate with them. They're like, dude, I can't do the special handshake with you. Your MHC is like non-existent to those guys. Because remember, they're programmed for our MHCs in our thymus. So if you get somebody else's cells that have a different MHC, those cytotoxic T cells can't communicate with those cells. So they think there's something wrong with them. And then who else scurries around and looks for MHC on cells and is going to kill them if they don't display MHC? Or one he recognizes anyways, the natural killer cells. Right? So it's your cellular response, it's your T cells, it's your natural killer cells that can't interact with these cells in the way that they should, and so they think of it as being a foreign thing, because it is. It wasn't yours to begin with. You weren't born with it, right? So these people need to take immunosuppressant drugs for how long? Their whole life. What happens if they stop taking it? They could reject that organ. Their immune system could reject that organ or tissue. And if it's an organ they need, which why would you get it transplanted if you didn't need it? You would die. So as I had mentioned earlier, right, these people are not going to festivals, they're not working in daycares with all those little germ magnets running around, because they're purposely taking immunosuppressant drugs to stop their immune system from rejecting that organ. So that leaves them more susceptible to infection. because they're purposely depressing their immune system to a certain extent. So the drawback to graft transplants is the possible immunological rejection, right? The immune system not recognizing it as self because it's not, right? This would, because it's T cells, this also falls under the type 4 hypersensitivity, right? What would happen if the administration of anti-rejection drugs were discontinued? There's the potential that they would reject the organ and die. So killing of graft cells, though a complex combination of mechanisms happens, the major players are sensitized T cells that start recognizing these as foreign, and natural killer cells, again, that aren't able to properly communicate with these cells because they're displaying a different MHC than we recognize. And that's where those molecules originally got their name, right? That's where MHC came from, major histocompatibility complex, right? It was a major problem when they were trying to figure out compatibility of organs. And then come to find out, the reasoning behind that is because that's what the T cells are communicating with, those molecules. So a combination of agents are commonly used to prevent that rejection. Autoimmunity, as the name implies, the immune system is attacking cell. And there's lots of different examples of autoimmune disease. We're going to discuss a few. I will not test you directly on any of these. All right, so it says give 4 examples. We're going to go over a couple of examples, but I'm not going to test you on specific examples. But it's important to discuss. And I don't want you guys memorizing huge amounts of information that you could easily look up nowadays on your smartphone. Right? But understanding this concept and how we believe it has come about in certain instances is important. So this is where, as I said, the body usually recognizes self-antigens and doesn't attack them. In this case, we are recognizing ourself as being foreign and attacking it, as if it is something dangerous. So we destroy our own cells or our own products of our immune system. It could be a malfunction in the immune system that's causing this rejection. There's also a belief of kind of cross-reactivity. So they believe that it may result from reactions to antigens that are similar to our MHC self-antigens. So, you know, like I talked about with the ABO blood group, right? You naturally are exposed to stuff that pathogens that have antigens very similar to our blood type antigens of A and B. So if you don't have those antigens, you end up developing antibodies against them. The reason why we don't produce them typically is because our immune system will not usually produce antibodies that could possibly react with ourselves. So that's why people with the ABO blood group usually don't produce antigens against A or B, because they have that antigen. Unlike me, where I have O-type blood, I probably have in my serum anti-A and anti-B antibodies of the IgM class. So the belief here is too that there are allergens that you're, antigens that you're exposed to that cause your body to produce antibodies that will bind to MHC. And so this can cause serious problems, again, because you are producing antibodies against your own body. And so therefore your own immune system is going to attack you. Other beliefs are that some sites of our body aren't usually exposed to the immune system, but then when we have injury, these sites can possibly be exposed. And when our cells are educated against self and non-self, these antigens weren't in that weed-out process. And so we had T cells or B cells that recognized self-antigens that they normally wouldn't come in contact with, but are because of the particular injury that happened. So there's still a lot we don't understand about autoimmune for certain diseases, where others it's pretty well understood. So these are some examples of specific as well as widespread autoimmune attack. So the one that most people are familiar with is people who have type 1 diabetes. And typically you're born with this, and what happened is that your T cells didn't recognize your beta cells in your pancreas and they destroyed them. The problem is your beta cells in your pancreas make what? Insulin. And you need insulin for your body to know that there's sugar in your blood for those cells to take up that sugar. Apparently they don't have the ability to detect that without insulin. The good news with that particular defect is we can just do insulin replacement therapy, right, for those individuals. In the case of rheumatoid arthritis, this is widespread, but mainly the problem is in the joints. And you have lymphocyte destruction of joint tissues, immune complexes building up in the joints of IgG and anti-IgG. So the belief here is that the people are actually producing antibodies against their own antibodies. And so then you have all these extra antibodies, and as we know, they can deposit in joints, and that's why it can cause serious problems for people in their joints. There is also some forms of rheumatoid arthritis where they believe that you're actually producing antibodies against components of the joint. And so the immune system is attacking your joint because it thinks that it's foreign. Yeah, in this previous picture, yeah, this was a severe form of arthritis over years of inflammation in the joints. And so again, the more and more they're learning about the different types of arthritis and the causes of it, you know, they're trying, and again, you got to suppress the immune system, right? A lot of these drugs are suppressing the immune system to try and stop this reaction happening here, but then that puts you at risk for other types of infections. One of the ones that a drug you hear on the news a lot, or on the computer, on commercials, is Humana, or what is that? I want to say Humana, but it's like that. Humana, I think, is a insurance company, but Humira, or oh God, I can't remember it. Why can't I think of it today? But again, most people are taking it or dealing with, you know, inflammatory immune response, so much so that it's damaging to the body. So you'll see it's prescribed for like colitis, which is inflammation of the intestines. I've seen it now advertised for psoriasis, which is inflammation of the skin. So for lots of different things. But it's an immunosuppressant drug. So one of the things they ask is like, you know, don't take this if you've had tuberculosis or think you have tuberculosis, right? If you have, you know, if you have serious infection, do not take, you know, right? And again, that's the reasoning behind it, is because they're suppressing your immune system, right? Not the whole thing, but, you know, to a certain degree. And that leaves you more susceptible to infection. So things like systemic lupus, these individuals have produced antibodies against your own DNA and other nuclear components, and you get that formation of the immune complexes. And again, that's why sometimes you'll see for them the rash that will develop, and it's for some reason women are more predisposed to this type of autoimmune disease than men, and they'll get a very characteristic rash on their face. And this is the immune complexes building up in the skin. They'll deal with arthritis, where again the immune complexes are building up in the joints. But it's really widespread, cause serious problems to the kidneys, again because of those immune complexes collecting in the kidney. Graves' disease is a really interesting one, where again it's a specific target where you're producing antibodies against the receptor for thyroid stimulating hormone. So normally from your hypothalamus, or your anterior pituitary? Yeah, your anterior pituitary. It's a supervisor. Hypothalamus is the big boss, right? Anterior pituitary is a supervisor who tells just about everybody else what to do, right, in the endocrine system. So they would stimulate your thyroid to produce hormones, right? The anterior pituitary produces a hormone that binds to receptors in your thyroid to tell your thyroid produce thyroid hormones, which affect a large part of your body. It regulates basically your metabolism. So the problem here is the antibodies bind to the receptor instead of the hormone. So then you overstimulate the thyroid and it produces more of the thyroid hormones than it should. And so you get this overexpression. And I'm not exactly sure what they do for treatment of this one. But again, all around not a good situation, right? When you have either antibodies or your own cells attacking your own body. It's not what's supposed to happen. So some examples of immunosuppressant drugs that they will give people is they'll give ones that will suppress dividing cells because your immune system is actively quickly dividing cells. This is why, too, when they do chemotherapies, it's typically targeting rapidly reproducing cells, which would be cancerous cells. But unfortunately, your immune system is rapidly producing cells as well. And so people who go through chemotherapy usually also have a suppressed immune system. So there are special drugs they give in that case to improve production of white blood cells and improve immunity during chemotherapy. Cyclosporin is a drug that's given that interferes with T cell signaling. So again, to try and combat that action of the T cells. Anti-inflammatory medications like corticosteroids, right, to stop the inflammation reaction, or commonly. And then the good news with diabetes, of course, is that they can do insulin replacement therapy. I want to say with with Graves' disease, they might actually remove the thyroid and probably do thyroid replacement therapy in that case to stop that overstimulation. But you can't survive without those thyroid hormones. So anyone who's had their thyroid removed, again, has got to take thyroid replacement therapy. And that's really, that's really hard to balance out. I have a friend that had a tumor and had to have her thyroid removed. And that's a nightmare, trying to find the right level of drugs and keep you going. And this brings us to our very last topic of immunodeficiency. So there's two main categories of immunodeficiency. There is primary, where it's genetically inherited, or acquired, right? Or what we call secondary. So how would immunodeficiency lead to infection? Well, deficient, as we said, means that the immune system is not functioning properly. So if it's not functioning properly, it cannot defend you against infection. So therefore, right, you're going to get infections. So primary or congenital, these are things you're born with. Or a developmental abnormality. Right? So you might not be born right away deficient, but your body doesn't develop properly and portions of your immune system are deficient. Secondary or acquired is a result of infection or other stressor. So there's something that's causing the immune system to be deficient that you have acquired. So examples of primary immunodeficiencies range from the most severe, which would be something like severe combined immunodeficiency, which is commonly abbreviated SCID. And this is where the bone marrow stem cells are defective. So you're not getting functional B cells and T cells. You basically have no adaptive immunity. This is typically what's referred to as the bubble boy. So I'm trying to see if I have my numbers here, right? Yeah. So neither B cells or T lymphocytes are functional because the defect is in the stem line, right, that gives rise to these cells. Notice the occurrence says 1 in 500,000 live births. So most people with this genetic defect die in utero, don't actually get born. Because this is such a severe defect. Something that's less detrimental will be something like selective IgA deficiency, where the people produce little or no IgA. That's just one class of the 5 classes of antibodies. Problem is that this one's a pretty predominantly produced one. Where does this one give us protection? In our secretions, right? In our mucus, our tears, our saliva, right? As you can see, this is the most common disorder, 1 in 333 to 700 people. Again, because it's not quite as life-threatening. What types of infections do you think they would suffer from the most, though, because they don't have any IgA? Eye infections, respiratory, gastrointestinal. Because again, not having that level of protection for your mucous membranes. And I actually had a student a couple of years ago, had a daughter that had A gamma globulinemia, and this is where her daughter produced very little of her own antibodies. And so again, this defect is in the B cell line, and this occurs about 1 in 50,000 people, and one of the main ways they treat people with this is they passively give them other people's antibodies. So she would go for treatment, and they would give her someone else's anti-serum. So again, those of you guys who've donated blood are helping out individuals like this by giving them antibodies that they desperately need because they can't make themselves. And she had a lot less illness and sickness after receiving, of course, these passive antibodies, this helpful treatment. Yeah, and it really depends, like, I don't know what the regimen is, but, you know, they monitor her, and depending on how she's doing, they'll either increase the frequency or decrease the frequency. I don't know a lot about that particular disease, but I've actually, like I said, a few years ago, ran into somebody. She's like, "That's what my daughter has." I was like, wow, that's crazy. Been teaching long enough, I'll probably run into all the disorders, right? So, okay, secondary, right? So these usually result from environmental rather than genetic factors. So certain malignancies can cause even advanced age and certain infections, right? As we age, our immune system is not as efficient as it was before, right? So that puts us at a disadvantage. Of course, individuals who are taking immunosuppressive drugs, right? They're purposely, for a legitimate reason though, right, suppressing their immune system. Malnutrition, right, can lead to serious immunodeficiency. Because remember, this is an army you must feed. If you're malnourished, you cannot support this army to defend you. So some diseases that really tend to really deplete the immune system and really keep the immune system focused on them, and therefore, you know, other types of things that you're exposed to, you're going to be more susceptible to. Syphilis, Leprosy and malaria are really, just hogs, you could say, of the immune system. So much so that they can overwhelm the immune system, make it quite deficient while the immune system is trying to combat it, and leaves you more susceptible. Malignancy, of course, in the lymphoid system can decrease antibody-mediated immunity by interfering with it. And actually what AIDS stands for is Acquired Immunodeficiency Syndrome. Because at one time, right, they didn't quite understand why these people had these symptoms, right? Why are their immune systems deficient? And they weren't born this way, right? So it's acquired, it's secondary. What happened to them? One of the major causes of people reaching this status that we refer to as AIDS was HIV infection, right? Because this particular virus destroys your helper T cells, which are CD what? 4, right? And it's actually that CD marker that that virus attaches to and destroys those cells that are so necessary, right, in our adaptive immune response. So you get to a point where the viruses have killed so many of those cells that the immune system is deficient. Back in the past, before the drug treatments and stuff we have, the antivirals that we have, if you had HIV infection, you were eventually going to end up with AIDS, where your immune system was deficient. Now, because of therapy, we have lots of people that are in the status of being HIV positive, but not having AIDS, right, where their immune system is deficient. And the bad thing is that those two terms pretty much became synonymous at one time, and people really don't understand that there is a distinction between HIV and AIDS and what that means. Okay? So the good news is now you're educated individuals, right? You understand that the true meaning behind AIDS is when someone has reached that status, their immune system is compromised. And they typically don't actually die of AIDS, because what AIDS is saying your immune system is deficient from something you acquired, right? You don't necessarily even die of HIV infection. You die of the fact that your immune system has become deficient and you get some other infection you can't defend against, and that infection is what kills you. Ultimately. Anyone know the major cause of death? People with AIDS? Pneumonia. Pneumonia. Right. Pneumonia is the #1 killer of people with AIDS.